Okay, so we're kind of trying to get both of these presentations right here together, following up from legislative and advocacy, knowing that telehealth has been such a big item. This next presentation is on telemedicine coding, being presented by Catrena Smith, who actually also presented for us at our January regional event in Gainesville. Catrena has over 18 years experience in the health information management industry, has served as medical record technician, medical coder, coding consultant, coding trainer, and coding manager. Presents numerous online and in-person educational sessions annually, and has written articles for industry publications as well as has authored one book. Catrena is an active volunteer with both nationally recognized health information and coding organizations, NEFHIMA and AAPC, and holds a number of credentials, including the Certified Coding Specialist, the CCS Physician Base, the Certified Healthcare Technology Specialist, and specializing in performance workflow. And then she also holds a couple of AAPC credentials, Certified Professional Compliance Officer, Certified Professional Coder, Certified Inpatient Coder, and Certified Risk Adjustment Coder, as well as Certified Professional Coding Instructor. And Catrena is also an AAPC Fellow. She prides herself in being able to help grow the next generation of health management and coding professionals. With that thought in mind, is telemedicine is our future. So if everybody would please give Catrena a warm welcome.
So let's see, I'm very southern, so it's going to be hard for me to stand still, but I'm going to try.
That's why I was going to roll around.
We'll see. Okay. We'll see, because you know on the other side that carpal tunnel. But, so before I get started talking about telemedicine, I did want to piggyback on the last presentation about mentorship. I actually mentor with NEFHIMA as well as that other organization, and it's one of the best things I ever do. So I think from my perspective as a mentor, I gain much more from them than they ever gained from me. So if you have the opportunity to participate in any kind of a mentorship program, I would recommend that you do that. So that's my mentor pitch. And so let's get started talking about telemedicine. And so I had no idea that the last presentation was going to talk so much about telemedicine, but I was excited when I got to see it, because a lot of that talks about Florida-specific things, especially when we're talking about the Senate bill, the House bill. I have some of that information here for you as well, but she did a good job explaining some of that. So of course, I make every attempt to ensure that all the information I give you is as accurate and up to date as possible. But with that said, especially this field, is like ever changing. I feel like every time I turn around, there's different stuff that we find out. So the main objective today is just to get a better understanding of the current coding and billing guidelines that we do have available for us that go through telemedicine. So we'll talk about what telemedicine is. Of course, we'll talk about the benefits of offering telemedicine. And of course, review what's covered by Medicare and just some CPT information. And then we'll have hopefully a good Q&A at the end of all of this. So the first couple things are just some important terms that we hear a lot when we talk about telemedicine. And this is my first time speaking about telemedicine in Florida, but I've traveled literally all over the U.S. speaking about telemedicine. And one of the interesting things is that some of the states that I travel to speak about telemedicine, they already have really good laws on the books that that we can look to for telemedicine. It makes it so much easier, right? Because we're not guessing about what may come or what may be. So telemedicine is simply using technologies to diagnose, monitor, and/or treat patients. And so when we talk about telemedicine, it's just technology plus medicine put together, right? You will oftentimes hear the term telehealth. And frankly, It does have a different definition, but most of the time it's used interchangeably. And so you will probably even hear me say telehealth sometimes today. Other times you might hear me say telemedicine, but I'm telling you I'm talking about the same thing, so that's my disclaimer up front. So telehealth is applying technologies to help patients manage their illnesses through improved self-care and access to education and support systems. So if you hear me say telehealth, I'm talking about the telemedicine definition. Does that make sense to everybody? Because that's really what most of us are talking about, even when we say telehealth or when we say telemedicine. So the next two important terms when we're thinking about billing and as it relates to telemedicine is there are different rules depending on what your site is. Okay? So the originating site is the place where the patient is. Okay? So whether that's the patient's in a doctor's office, the patient's in a SNF, the patient's at an acute care hospital, in the ER, wherever the patient physically is located at, that's our originating site. Our distant site is the site where the practitioner that is treating that patient via telemedicine is located at. Okay. So with that in mind, there's a lot of places that a patient could be when they are receiving telemedicine services, right? So I just gave you a couple, like in the ER, they could be in a doctor's office, they could be in a SNF. What are some other places that you think a patient might be physically located when they're receiving telemedicine services?
Home.
Correctional facility, home, right?
Nursing home.
Nursing home, right? So there's a lot of different places that the patient can be at. The next term that we talk about is asynchronous or store and forward. That is not telemedicine. You know, that's where data is being sent. With telemedicine, it does need to be a real-time communication, audio and video between the patient and the provider. Okay, so it's not just talking on the phone. We'll talk. I heard you mention Skype earlier. We're going to talk about that a little bit today because that's a common question that I get. But why telemedicine? Well, I think the last presentation did a good job of explaining why telemedicine, so she did my job for me as far as that goes. But you want to make sure that patients, mostly in rural areas, are able to get access to certain types of healthcare services that either they otherwise would not be able to get access to, or it would be very difficult for them to get access to those services. It could be because of location, like I say, rural, but it could be because of the patient's health status, based on maybe a disability or mobility issues, things like that. The patient could be in a big city where there's docs 5 miles down the road. That doesn't mean that the patient can easily get there, right? So that's one thing that I hope in Florida that they address with telemedicine legislation. Is making sure that it's not limited to only patients in rural areas. And so, of course, also for providers, maybe in a larger area where there's more specialists, they can be able to provide consultative support to some of the providers in the rural setting. But even in that instance, with the consultative support, that consultant still, in order for it to be telemedicine, would not only be talking to that other provider, they would also need to have, again, real-time communication, both audio and video, with the patient as well in order to close that telemedicine gap. Okay, so payer requirements. I'm going to talk to you a little bit about that. On the commercial side, I almost laugh when I say this. Coverage varies by payer, right? We know that, right? You've got some of them that, that will cover telemedicine regardless of where the patient is. It's like that's just their policy. They'll cover it. You've got other ones that have, different rules where maybe the provider has to fill out an application to be approved to offer telemedicine services for that particular payer. So there's just a lot of different things and too many variables there for us to say this is the set thing that you need to do on the commercial side. You really will need to look to each payer that you're deciding to offer their patients telemedicine services before you offer the telemedicine services, and see what their guidelines are, because it can vary. And you want to, again, do that prior to rendering the services. So this is where I tell my story. So if you've ever heard me speak, I tell stories a lot because things just happen to me that kind of go along with this. And this is actually how I wound up doing telemedicine presentations. I went to the doctor in Orange Park where I live, and I thought I was seeing the doctor. And I was in there, and they gave me a form for telemedicine. I read it kind of, you know, but not really, because you got to sign it if you want to be seen anyway. So it's like, I'll read it later is kind of what I thought. So I filled it out, and I was like, well, that's weird. You know, I'm here to see the doctor. Why would they, you know, be giving me something for telemedicine? Here's why. I go in the room with, you know, and the tech, you know, does my vitals, all of that stuff. And she says, hold on a minute, let me pull up the computer. And I said, well, why are you pulling up the computer? She's like, oh, the doc's over in Ponte Vedra, and so he still wants to see you, but he's going to do it over the computer. And I said, you mean telemedicine? And she said, yes. And I said, well, I have Blue Cross. I said, how do you know Blue Cross is going to pay for this? How do you know that, you know, this is going to be okay? Like, and she says, oh, it's okay. We just bill it like the doctor was here and they pay for it. They don't. Yeah, I kid you not. This is a true story. And so I'm sitting there and I'm thinking, like, who's like punking me? Like, is it, I'm waiting on the chair to come out. I was like, this is not cool. This is not cool. And so, because of that experience, it made me start looking into telemedicine. And I found some very interesting things. And so, for the past 2 years, I've been presenting on telemedicine. So some of them do have a process for being approved for the providers to be able to offer telemedicine services. And there's, depending on the payer, there's certain billing requirements. We'll talk about Medicare and the place of service code. We'll talk about all of that stuff today, and some guidelines they have, like for the HCPCS code for the originating site versus the distant site. I can tell you they didn't do any of that stuff because I did look back. But and you also want to see, like, if you get approved by, on the commercial side, if there is an approval process and you get approved by that particular payer to offer telemedicine services, you do want to make sure that there's not some specifics as far as the patient's location or certain conditions that the patient may have, but also certain services. Usually, even if telemedicine is offered, there's limits to what CPT codes or HCPCS codes can be billed, you know, because, you know, they're limited to what can be offered via telemedicine. So I included just some information here in the slides, but we talked about that stuff, right? And the Medicare originating site is the same thing that we're going to, we talked about the originating site before. That's where the patient is physically located when the telemedicine services take place. And so Medicare has some real specific requirements. The originating site must be located in a rural health professional shortage area, or HIPSA. I'm just used to saying HIPSA. Located either outside of an MSA or in a rural census tract, or a county outside of an MSA. So it's like, okay, how do I know what in the world that is, right? I included in the slides a link to the Medicare website, and what you can do is, if that patient has Medicare, you can plug in their address on that website, and it will tell you whether or not, from a Medicare perspective, that patient qualifies as being able to receive telemedicine services. And I've plugged around addresses, of course, you know, like family members and stuff like that. And I have yet to see one of those, and some of them live in like small towns, but I have not found any address personally that did meet the requirement, just so you know. But I know there are some. I just haven't come across any. So there are some exceptions to this. It doesn't apply to us. That's for Alaska and Hawaii, but I just included it for you to have it there. So Medicare has some specific requirements as to what the originating site may be. And so I asked earlier, what are some of the originating sites? And we talked about it could be a correctional facility. We talked about it could be the patient's home. I don't know if I heard it today, but sometimes people will say, well, maybe it could be the school, right? It could be the school. So there's a lot of places, but if it's a Medicare patient, they have specific originating sites, and home is not one of them. Home is not one of them. So it could be the physician or practitioner's office. It could be a hospital, whether that's the inpatient hospital or the patient's an outpatient in the hospital. A critical access hospital, RHCs, FQHCs, or hospital-based or CAH-based renal dialysis centers, skilled nursing facilities, and then community mental health centers. So some of the locations that we might see healthcare services take place, you don't see them listed here.
Hospitals, does that include long-term acute care and rehab inpatient?
Yes, it does.
Thank you.
So the Medicare distance site, okay, remember the distance site is the place where the physician or other qualified healthcare practitioner is located at, right? So that originating site is where the patient is physically at. With the distance site, what Medicare guidance says is that it's got to be one of these provider types, and you can see them all listed there, and physicians, nurse practitioners, PAs, no, physicians, and then those non-physician practitioners that we commonly talk about, right? I do like that they included registered dietitians and nutrition professionals, because especially when you think about some of our like patients with obesity or even some with eating disorders and things, I like that they included that on there. You see an asterisk by clinical psychologists and clinical social workers. And if you are working in a setting where you're coding or billing for those types of providers, and you're thinking about offering telemedicine, I would recommend that you dig into the Medicare guidelines. I don't have all of that memorized, but I can tell you there are some limits to what clinical psychologists and clinical social workers can offer to a Medicare patient. Again, this is just Medicare. That may or may not be the rule if you're talking about a commercial payer. Okay. Yes.
You say on the subject to state law as in the state that the provider is located or that the patient is located if it's different?
Well, most of the time this is talking about in the state where the provider is, but let me take a step back. I was going to address this a little bit later in the presentation, but I'll address it now. Certain states, if you're crossing state lines, in certain instances, that provider will have to be licensed in the state that they are physically located in and the state where the patient is located in. So if that is the requirement, then it would have to be based on both states' guidelines. Does that make sense?
Yes.
In other instances, the patient may, or the provider may not need to be licensed in the state where the patient is if it crosses state lines, and that's just going to vary by state. Okay. To the best of my knowledge, in Florida, whether the patient is in Florida or the provider is in Florida, they would have to meet Florida's guidelines.
Okay.
So, I told you this earlier, for telemedicine, there are some equipment requirements, and it has to be interactive, audio and video telecommunication between the patient and that provider. Okay. So, what do we think about some of these options? Like you've got different apps on your cell phones and different things. I hear about those all the time, and it's like, well, what about that? Literally, what do we think about that? What do we think? Do we think just the app from the App Store might be okay? Hopefully everybody says no.
Let's just FaceTime.
Yes, I hear FaceTime, I hear Skype, I've even heard WebEx. Yeah. But the thing is, you have to make sure that whatever modality is being used, A, it has to be real time, and B, it has to be HIPAA compliant. It's got to be HIPAA compliant. So I'm going to address Skype specifically because that's the one that I get asked mostly by the doctors. why can't I use Skype? And what I tell them is Skype Business actually does have an option where it's like encryption and it has, you know, what it needs, and they'll do a BAA and all of this stuff, right? The problem with that is only one side of the communication is HIPAA compliant, because the patient on their end, remember, they're using their own to sign in. And what's the likelihood that the patient went through paying for Skype Business and getting, you know, making sure that it's encrypted and all that stuff?
Yeah.
Unlikely. I would say highly doubtful.
Yeah.
So that's my issue with that piece, and I'm only addressing that one because that one is asked every time I meet with docs.
Yeah.
I personally would not, I would not be recommending that because I can only see one side of that being covered, not the other side, and both sides need to be covered. The same thing when you have some of these or some of these programs that are housed on servers outside of the country. You might have an issue with being able to prove that it's secure. Because remember, I'm not going to turn this into a HIPAA conversation because I can do that. But the thing is, even if you were to get a BAA from that company and have like a set, you know, like they say they follow the guidelines, how would you be able to audit them to know that they are complying? That's my issue with those. But there's lots of programs out there, and a lot of times the different medical societies will give you options and things like that. On the mental health side, if you go to the Telemental Institute, they have, you know, some recommendations and stuff on there. So I don't recommend specific programs or specific software for telemedicine. There are some out there that are inexpensive. There are some out there that are astronomical. But I don't make recommendations for each one because, frankly, I don't know enough about how the information is stored in order to be able to comfortably do that. Yes?
Has Medicare audited telemedicine? First question. And second question, how do you do release of information?
Well, I'll take your second question first. Release of information would be the same. So the information, when the visit is held via telemedicine, it's documented in the patient's medical record. That's a requirement. And so what is released is that visit information.
Not the video.
No, they don't. You don't record the. You don't store the video itself.
Oh, you don't store.
You don't store the video itself. Now, some of them could. I've not heard of them doing that, but that would definitely not be the norm to store the video itself. Yes.
Even just with the video, is there a different consent form for that? For the recording, is there a different consent
Usually,
form?
yeah. I would imagine there would have to be a different consent form saying that you agree to the recording. But like I said, I've talked to, at this point, hundreds of providers. I don't know. I haven't met any of them that are actually saving the recording. So the HIPAA issue isn't the recording part. It's the real-time communication that someone could just simply hack into, you know. Yes.
What about the protocol?
I can't hear you. I'm sorry.
The neurologist that I worked for in the past, he's a telemedicine preferred protocol. Would they not, because he goes at remote, the machine goes in and goes right to the patient with the other providers that are there. Would they not say that because in case what if the patient didn't survive and, you know, the attorneys grabbed hold and said, well, you know, you missed that diagnosis because, you know, would there have to be anything for documentation and video for that?
I think a better person to ask that would be the physician because, again, I've talked to hundreds of physicians. I don't know any of them that have told me that they are saving the recordings. Instead, what they're doing is documenting the visit, which they are required to do. And most of the time, even it doesn't matter which state you're in, the requirements are that if you see a patient, it has to be documented. And of course, from a billing standpoint, it has to be documented. I have not seen anything that speaks to, from a legislative standpoint or from a billing standpoint, that requires them to store the recording. And that gets into a whole other issue because they would be having to pay for storage, and that can get very costly.
Even just legally keeping that and, you know, what part is part of the record.
Exactly.
And subpoenas for.
Exactly. Yeah, it's not something I would even recommend on a routine basis. So let's talk a little bit about the Medicare physician fee schedule. What happened with 2018 is that there was the addition of several codes that are now covered by Medicare for telemedicine that were not previously covered. Okay? And so that's good because each year we keep seeing the list grow of codes that are covered by Medicare. They also removed the requirement of a GT modifier. Previously, all the way up through January 1st of this year, if a service was provided to a Medicare patient via telemedicine, they require modifier GT to be appended to that particular CPT or HCPCS code. That changed on January 1st because in 2017, they added a place of service code 02. And the 02 place of service code specifically says it's a telemedicine visit. And so it was redundant to have the 02 and to have the GT modifier. I personally liked having both because I'm just big on data and you want 2 points. You want at least 2 data points to pull from. But they removed it because they said it was a burden on the providers. Okay. So back in 2017, also what happened is there was the addition of the star icon in the CPT book. They also added modifier 95 in the CPT book. So this is where we come into another difference when we talk about commercial payers versus your government payers. And where previously on the government side, both Medicaid and Medicare, we would have to append, again, modifier GT back in 2016 and 2017 and all that. We don't do that now. But in 2017, CPT added modifier 95. Modifier 95 says it's a telemedicine service. So the two modifiers say the same thing, both GT and 95. Does that make sense? So what happened is, for some of the commercial payers that did have telemedicine policies, they now said use modifier 95 versus modifier GT. Some of them said it didn't matter, right? But now that Medicare does not require the GT modifier, we have modifier 95, the thing I want you to be mindful of is that that is based on what the AMA identifies as a telemedicine code. Okay? That's based on what the AMA identifies. Remember, the AMA, they're the ones that publish the CPT book. So when you see an icon next to that, it is not for payment issues. It is a CPT issue. Does that make sense? So there are some codes that actually, if you look to some of your commercial payers as well as Medicare, if you look at their policies, there are some codes that are covered via telemedicine that do not have a star icon in CPT. They do not have a star icon in CPT. So what I recommend is if you have a payer that you know you're offering telemedicine services and you have a specific payer, I'm one of those that I always keep a hard copy CPT book. I think I always do that as long as they have them because I like to make notes and highlight and underline and all of that stuff. So what I did in my CPT book is I went through and I starred and I put, like if it was Medicare, I put CMS next to it. That's what I did so that if I did want to take a look back at a specific code in the book itself, even if it was not covered or if it did not have a star icon by CPT standards, I'm not billing the AMA, I'm billing the payer. So I want to know what the payer says is appropriate for telemedicine. Okay, so, and I told you they added modifier 95 and addition of Appendix P as in Paul, which Appendix P is just a summary of all of the CPT codes that the AMA has identified as telemedicine codes. So, you don't have to remember all of that, I just put them there for you. You can go to Appendix P. That's probably the best way to do it. But there are 79 codes that the AMA's CPT book has starred as telemedicine codes. But Medicare covers 94. Some of them are HCPCS codes, but still they cover, there's more than 79 that are CPT codes. Does that make sense? Okay. So Also, what CMS did for 2018 is they added certain psychotherapy codes to the list of codes that can be covered by telemedicine. So I included those here for you, and then they also added health risk assessments that can now be offered via telemedicine. They offer, I don't know why that changed it to an I, that should be an L, LD CT, low density CT eligibility for those lung cancer screening patients. That one, GO296, is now added to the list of codes that are covered by Medicare under telemedicine. And then your comprehensive assessment of care planning, and that's when we talk about those chronic care management services. So I included a table here just to give you an idea of what all of the, like the categories of the CMS cover telemedicine codes. We're not going to talk about all of them, but I did want to mention some of your end-stage renal disease services. They are covered by CMS to be offered via telemedicine. Again, with your commercial payers, you want to look to that specific payer's policy because it can vary. But many of them that I've looked at also cover some of these as telehealth services. But many of them do not have a star in the CPT book. So that's why I want to point those out specifically. Your medical nutrition therapy. And really, when we think about it, those diet professionals and medical nutrition professionals, these are primarily the codes that they're going to be using via telemedicine. Doesn't mean it's limited to them, but that's mostly going to be them. Also, 99211 is not starred. All of these other E&M codes are starred in CPT, but 99211 in red there is not. So, take that for what it's worth. How often are we really using 99211? Because if we think about it, a nurse, for Medicare, a nurse is not listed as an approved provider of telemedicine services, right? So although we know that a doctor can use 99211, how often is that really going to happen? I've never seen it. Most of the time it's at least a level 2, right? So, but they have it on there, just I want to point that out. They have it listed. Some other E&M services, you'll see subsequent hospital care. You do not see initial hospital care. Okay? Subsequent hospital care, but not initial hospital care. Any ideas why we would not see initial hospital care?
Patient needs to be established and the problem needs to be established before it can be a follow-up, and telemedicine is primarily follow-up and maintenance of a problem.
These are like inpatients in the hospital, so that's a little bit of a different. Any other thoughts?
During commission, H&P has to be done face-to-face.
Bingo. Bingo. So that's the, even, and the argument there is, well, telemedicine is face-to-face. Well, yeah, it is, but it's not. You know, it's they're seeing them real-time audio and video telecommunication, but they are not physically in the room with the patient, laying hands on the patient, examining the patient, talking to the patient, you know, and or their family members and things. So you won't see that on here. I was surprised to see prolonged E&M codes on the list covered by Medicare for telemedicine, but it's there. The smoking cessation, this is one where, you know, there used to be G codes that we used for that, like in the clinic setting when they would do tobacco cessation counseling in the clinics. Those codes went away, so for 2018 we used the codes that already existed in CPT, and that's what we do for telemedicine for CMS. So there's that. I will tell you one thing about just from an audit perspective with the tobacco cessation counseling. Some providers don't pick it up at all, and this is not just a telemedicine thing, I'm just going to tell you something in general. I noticed that some providers don't pick it up at all, even though they do it almost every visit. But it is something that, you know, if it takes the time away and it is being done, that I do recommend that it be captured. not just only for, a payment perspective, but just so that you can be able to calculate, well, how many times has this patient, received tobacco cessation counseling in our clinic? And then at a certain point, if, say they've been doing it every visit for the past 5 years and the patient's like, nope, not having it, then you might think, okay, is it medically necessary to keep having the same conversation that the patient doesn't want to have? But if it's being done, it is something I recommend that you capture. But your time does need to be documented, and it's got to be separate from your E&M, your regular E&M service. Transitional care management, I love that they have these listed on there as being covered by telemedicine policies, at least for CMS. And does anybody know what transitional care management is? Okay, transitional care management, really, I think the main goal of that is to keep patients from being readmitted to the hospital. And it's evaluation of the patient. The provider takes ownership or responsibility of that patient immediately after discharge and for a period of 30 days thereafter. And so it includes some things like they've got to do a phone call within, I think it's like 2 days. They have to contact the patient to do more than just schedule an appointment. It's got to be a medically necessary conversation. They're doing medication reconciliation. It includes one office visit and things like that. So it includes a lot of stuff. But the goal there is to take these patients that have moderate or high complexity and that were discharged from the hospital inpatient setting and are transitioned to the community setting, the community setting. So it does not include a patient going from the hospital to the SNF, but it may include a patient going from the hospital to to home. Even if the patient's on hospice, for example, if not a hospice home, but if they're transitioned to their home and they happen to be on hospice, this is also something that might be appropriate.
Would this count for assisted living?
What was that?
Would it count for assisted living?
Yes.
Since it's not so medical?
Yes. What was that?
How would you document that? So the physician practice would have to document that they called the patient and discussed discharge planning and medications, et cetera, and document it in the physician record?
It has to be, it's got to be documented. There's more involved in transitional care management than that, but that is a piece of it. It also involves making referrals to the appropriate, resources that the patient may need. It also involves, like I said, a face-to-face evaluation and management service, and it lasts for 30 days. And so if the patient expires prior to 30 days, then you can't bill the transitional care management. But for the patients that don't expire, then I think it's good to capture this. Because a lot of times what I see happening is the providers are doing this. They are already doing these things that are covered under transitional care management. They're just not capturing it that way. Instead, what's happening is the patient gets discharged from the hospital. The patient's scheduled to come see them usually within a week of discharge. They see the patient and they're billing it out as a regular evaluation management code, which is going to get them a lower payment than if they capture what they're already doing, which probably is the transitional care management. So if you do want to know more about transitional care management, at least from a Medicare perspective, they have a whole manual, a MedLearn manual on how to capture transitional care management services. They also have diabetes management, whether it's individual or group covered. And then I told you the counseling visit to discuss the need for the lung cancer screening, that low density CT. That one is covered under telemedicine.
I have a question on the lung screening. At our hospital, that's usually done by a nurse. So do you see it in the future where nursing will be covered?
No, because this is the visit by the physician to determine the need for low density CT. Does that make sense? This is an evaluation and management visit, so this is going to be something that's either a physician or a non-physician practitioner. Do I foresee nurses being able to offer certain services? probably not for a long time to come. I can't imagine it. I mean, as much as we're fighting to even get telemedicine covered by, physicians, I can't imagine it would be a quick thing for them to be able to, for them to allow, that certain stuff to be covered by nurses.
The reason why I ask is from the oncology standpoint of the survivorship care plan being going over by the patient once they're discharged from oncology. That was the reason.
And then you have to think, would that be a real-time audio and video telecommunication? Because that's what it would have to be if it were, if we were even to consider it as part of telemedicine. And so that's probably not, I know, I don't do much with that, but I know, like I have an uncle who works in tumor registry. And so he's told me, some of the stuff that he does, like the follow-ups and the phone calls and all of that stuff. And, if that kind of is a little bit of what you're describing, if it's a phone call, if it's a phone call, it's not going to be telemedicine.
Not necessarily a phone call, but I do work in the registry, so that's what I was asking about, the survivorship care plan, though it has to be done by a medical professional, so that was the question. In the future, do you foresee that happening?
If it is, it probably wouldn't be in the near future, but I doubt it. I doubt it would be something covered under telemedicine. I've been known to be wrong from time to time, but I doubt it. I doubt on that situation that they would for at least any time soon. So inpatient follow-ups, these are consultations. The funniest thing ever to me about this whole telemedicine thing, I literally laughed when I first was reading the telemedicine policies and I saw that there's certain consults that are covered. This is the Medicare policy. How much has Medicare beaten us down about consults, and you're not doing them right, and these are not consults, they're referrals, and you're not capturing them right, and we're just not going to cover any of those consult codes. Now that we have telemedicine, guess what we have? Some consult codes. So now this would be inpatient consults for patients that are inpatient. They also have some for patients that are critical care. There are some limits to it, so it's not like you can have a consult captured every day. And even on the subsequent hospital care, so let's say it's out of the consult and that provider is following them now via telemedicine, there's even limits, like time limits, to how frequently those visits can take place.
Is that 15 minutes or 15 days?
15 minutes. 15 minutes.
Okay.
Approximately 15 minutes. And remember, that's the short descriptor there. So even with our regular E&M codes, they have times associated with some of that stuff. Doesn't mean that we're always coding by time. So let's see. These are inpatient ED. These are your initial consults. So on the previous slide was your follow-up consults. This would be your initial teleconsult, and that's the average time. So 30 minutes, 50 minutes, or 70 minutes, and they've got G codes for that. Again, emergency department or initial telehealth. And then there's various other services that CMS covers as well. So behavioral counseling for obesity. And although we might see some of that stuff by a physician, we tend to see that, of course, by nutritionists or dietitians.
So going back to the other slide, you said ER department, would that be the ER physician doing telemedicine with another physician?
No, remember, for these telemedicine services, it's a physician and a patient, not a physician and another physician. So this would be a patient is in the ER, they're being seen by an ER physician, and that physician needs to consult with another provider, needs to have another provider consult with that patient via telemedicine.
Okay.
So that telemedicine encounter, assuming your 3 R's are met, would be reported with these codes rather than your regular E&M codes.
Thank you.
You're welcome. So there's a bunch of other stuff there. So as we kind of get ready to close, thinking back to the originating site, remember that's where the patient is at. The way that Medicare says bill this is you bill it with Q3014. So let's say this was a telemedicine encounter And the E&M code that the telemedicine provider at the distance site billed was 99214. Let's just say it's that, right? At your site where the patient physically is located, you are not going to bill a 99214 because your provider did not provide the evaluation and management service. What your provider did was provided room and support for that distance site provider. And so what they bill is HCPCS code Q3014, and they get about $25 for that for basically providing the room. Sometimes what will happen is the distance site providers and the originating site providers, they may come up with an agreement that when it's medically necessary, they're going to have someone at that distance site perform a particular type of exam. I see that a lot with wound care. So with wound care, also with dialysis patients, where the site does need to be evaluated, like face-to-face by a provider, they need to physically lay eyes on it. So for those, sometimes they'll have different agreements about that, but from a billing perspective, it's going to be HCPCS code Q3014. That's what, if it was Medicare, that's what you would bill. If it's a commercial payer, it would just kind of depend on, what they say. Some of them will take the Q3014, but I've seen some that don't even really speak to a facility fee. So, kind of that one. For the distance site where the provider is, they're going to be a place of service 02 on their claim form. So, even though that provider may physically be located at his or her office or at another hospital, they are not going to use the place of service on that claim that corresponds with where they're physically located. They are instead going to use place of service 02. Again, this is for the distance site provider. For your commercial payers, check their guidance. Some of them want the 02, but other ones don't. They want you to still use the place of service for where that physician or other qualified healthcare professional physically was located. Now, this is the part in the presentation where folks tend to ask, well, what about if the physician is at his or her home? Because if you think about it, that kind of makes sense. The physician may be at their home. What I'll tell you is you have to look to that specific payer guidance. If they do not have their home listed on the application as a place of business for their practice, then usually they're not going to be able to offer telemedicine services from, I'm talking about the physician now. They would have to be at the location that is listed as their place of business. Okay. So that's kind of it with that. I included kind of this stuff here. Medical necessity, just remember that all services do need to be supported by medical necessity, and I have not seen, at least from my standpoint, I haven't seen any auditing, at least from the payer side where, we've been requested to send documents or anything like that. What I can foresee is coming. I mean, of course it's going to come. So you just want to make sure everything's there. I included some information here for services furnished to patients in SNFs. This is Medicare information. I didn't want to go through it too much, but I just wanted you to have it in the slides. But there are some specific requirements if the patient's originating site is in a skilled nursing facility when they receive telemedicine services.
I would assume that you would need to document that in your consultation, that this was a telemedicine consultation, blah, blah, blah.
Yeah, we're going to get to all of that in just a minute. So with your consults, remember still medical necessity. It's got to be a request for opinion, advice. It could be a suggestion or direction. It is not a transfer of care. Those things that we didn't have to worry about too much because, at least from a Medicare perspective, we didn't have to worry about it too much because they said we're not going to cover those codes anyway, right? You need to report it differently. Now we have to think back when you're billing those, let's say the patient's in the ER and your provider does a telemedicine consult, or if the patient is in the inpatient setting and your provider's doing the consult, you absolutely are going to need to think back to those consult requirements that we used to follow. And here's what you were looking for. So this is an example of a telemedicine progress note. Some key things, of course, with some variances, you would want to make variances for your practice, but you want, of course, the visit date. That kind of makes sense, right? Patients, demographics, all of that stuff that we would normally have. But I highly, highly recommend, even though this is not anywhere in the guidance, I highly recommend that you have a statement stating that that visit took place via real-time audio and video telecommunications, and you not just slap telemedicine visit on the top of the progress note. It's just my opinion. It also does not state that you must say what the originating site was, but we know that there are originating site requirements, so why would we not state what the originating site is on the note itself? And then the same thing with the distant site. State what the distant site is. I just believe in giving as much as possible so that if there's an audit, there's less likelihood that you're going to ask for more. You're going to say, you know, denied, and then I got to figure out what it is you denied it for, or they denied it
Does
for.
EHR have this template?
Well,
Some of your electronic health records, are they utilizing a template just specifically for telemedicine?
yeah, and it's one that, I mean, templates are mostly developed in-house anyway. I mean, most EHRs have some standard ones, but even those are going to be tweaked because there's variances in how providers document. So will an EHR automatically have one? Probably not. It would be up to that organization to develop one.
So is this your form or Medicare's form?
This is my form. Well, not my form. It's a form I developed for a client. Put it that way. Technically, they own it. So some payment concerns, subsequent hospital care visits. I told you that there were some limitations to that. You can only bill that once every 3 days. The thought is if that provider that is seeing that patient via telemedicine needs to see them more frequently than that, then they need to go to the hospital to see the patient. And then the subsequent nursing facility visit services, they're limited to one telehealth visit every 30 days.
The same idea.
Okay, so as we get ready to close, just know the payer's policies. I talk a lot about CMS policy just because theirs is clear cut, it's concise. If you wanted me to talk about commercial payer policies, there are too many for us to even be able to discuss here today. But hopefully you've at least gotten some nuggets or some tips at what you can look at for your commercial payers to help you with that. Not all payers are going to follow Medicare guidelines, especially when it comes to what services are covered and how they are captured. So for example, for some of your consults, if a patient's an inpatient, some of your commercial payers may not want you to use those G codes. They may want you to use those, 9925 E&M codes. They may want you to use that. So the biggest thing is know your payer's policy before you start offering telemedicine services, A. B, the originating sites, unless your payer says differently, they're going to report Q3014. Do not make the mistake of trying to bill what the provider that actually saw the patient billed, because that's going to be an issue for you. It might not be an issue for you that day, but it will be an issue down the road. So don't do that. Distant sites should bill the appropriate CPT or HCPCS code for whatever was done. Now, there are some barriers to telemedicine, and one of the biggest ones is cost. And it's because, you know, how can I say this PC? It's morning, so I shouldn't be too tired to speak, you know, politically correct, right? But you find that sometimes folks want the cheapest option or the free option. And what's the likelihood that a free option, think back to the beginning of the presentation when we talked about HIPAA compliance. The free option probably isn't going to be your best option. So do your research before you even look into what telemedicine software you're going to use. Reimbursement rates has gotten, of course, payer guidance, we've talked about that. That's a barrier because we just don't have consistency. In some of the states where they have like actual legislation or actual laws on the books that say what's covered and how it's covered and all of that, those are awesome because you don't have to guess. And they make all the commercial payers follow that. And then, of course, Medicare would be at the national level, so it would preempt any state So if it's a Medicare patient, there's some states, I think Colorado is one if I remember correctly, where all patients, if they're covered under insurance, the payer has to offer, if they offer telemedicine to some patients, they have to offer it to all, regardless of where they live at. And, but if it's a Medicare patient, you wouldn't follow that because federal law is going to preempt state law. And if Medicare, which falls under federal law, says there are limitations to where the patient has to be located at, then you're going to have to follow that. We don't have that issue in Florida because we don't have anything right now telling us. But hopefully, with the help of NEFHIMA and FEMA, hopefully, and some of the other regional associations, we can get there one day with Florida. I'm hopeful.
Along the lines of costs, are there third-party application providers right now? Are there?
There are many.
And based on usage, or do they charge a fee?
It depends. Some of them it's based on usage. Some of it's like a price up front, and then you pay a monthly amount, and it doesn't matter how many visits. So it just really varies based on whatever their model is. You do want to have a contingency plan for when there's connectivity issues, because again, it has to be a real-time audio, video, telecommunication. So what if the camera goes out? Or what if it's foggy? Or what if you get dropped from the call? Is that an effective visit? No. Okay. So you got to think about that. And sometimes patients just are not open to this type of visit. Okay. So the last thing, if you want to look up legislation pretty much on any state, it tracks things that are already on the books as well as things like going through the legislative process. I don't think it's real time because I have seen some stuff like when we got the update for Florida, I think it was like last month. When I looked, it was a couple days later, I didn't see it on here. So just understand it may not be updated real time, but at least it can give you an idea of what's going on at the state level. For any mental health providers, Telemental Health Institute has a lot of information for you on there. And then this is the website I told you can go to plug in that patient's address.
Have you found, a couple of slides back, you said that one of the barriers could be the patient's acceptance of telemedicine. Have you found that the physicians in Florida, for example, is open to the idea of telemedicine, or is there still a lot of resistance from physicians?
I don't know. I can't say it's more one or the other.
Okay.
At least in my experience, it's kind of like 50-50. Some are open to it, some are not. I find a lot of the older providers are not. The younger ones,
Be more
so. But that's just been my experience. And it spans more than just Florida, so.
But it has to be it has to be both the specialists getting on board as well as the family medicine doctor, the private doctor getting on board as well.
Right. It takes a lot of people being, agreeable to it. I think my time is just about up, but I did want to, where is it at? Wanted to show one thing. If you wanted to take a look at,
You got 5 minutes.
okay, if you wanted to take a look at the Senate bill that we were talking about before, not the Senate bill, I'm sorry. This is from the Board of Medicine. Got mixed up. This is from the Board of Medicine. And we actually do have some standards from the Board of Medicine on telehealth services here in Florida. And so I included that here for you. I'll send it to you so that if you want to post it later, you can. But I just wanted to include it here. One of the things that I know was recently making its round, at least with the Board of Medicine here in Florida, whether or not they're going to allow the cannabis oil or the low THC to be prescribed via telemedicine. It went through the rounds a little bit, and then within the past few months, they killed that one. So I don't know if it will be reintroduced a little bit later. But this is at least what we have right now for the state of Florida. And a lot of it really matches what we're already talking about, like the certain types of providers that you would expect to offer services via telemedicine, the fact that it's got to be documented as telemedicine. You can't purport that it's a regular visit, you know, all of that stuff. So, like I said, I'll email you a copy of this too, so that if you want to add it on the website.
Okay.
So we have any questions?
So I'm really interested in this cost concept. So it probably depends on the situation, whether it's like kind of leased versus buy or capitalized or not.
I haven't seen any that are buy.
Okay, so it's
'Cause there's
all, okay, so that's how you reduce the cost. You share with, you know.
Any other questions?
I'm still battling that you still don't have, are required to save the video or audio. Hospitals that perform surgeries and do, you know, the cameras are required to save that. I think eventually if somebody gets audited, how do you prove that it was telemedicine? The audio and video are the only key components.
Well, I mean, if you think about it, you've got a consent from the patient signing that they agreed to receive the services via telemedicine. And then, so that's acknowledgement from the patient that there was going to be something telemedicine. When you tie that with the documentation that also says it's telemedicine, in my opinion, that is good enough. Now, if they were recording these telemedicine visits, then absolutely I think it should have to be retained, and then you've got to get into the retention laws, and is it going to fall under 10 years or is it going to fall under 6 years, which I don't know, frankly, because it's not something that's been addressed right now. So you know, you would probably have to do that at that point, but I can't imagine why they would need to in most situations. Now, there may absolutely be times where there's pictures taken, and I can think of like skin cancer, things like the patients with fistulas, wound care. And if we think about it, they're already keeping pictures of that stuff on charts now. So it wouldn't really be any different. They would take the pictures remotely, and some of these products allow them to be able to do that. They would take the pictures remotely, and it would still wind up on the patient's chart. So I don't think there's really a need to have a recording of the actual words that were shared between the patient and the doctor, in my opinion.
If that's the case, then I'm with you with that, because if that's the case, when I go into my doctor's office now and have a conversation, they're not recording that.
Right.
So why record if I'm on the computer? So, yeah, I'm with you with that. That shouldn't be an issue.
I know there have been times, absolutely, that I've gone to the doctor and they said one thing, and then I went back later and it's like, oh, that's not what I said. I'm like, look now. I know that's
I
what
wish it
you
would have been recorded,
You
but
wish it had
it
been recorded,
wasn't.
but you know, my time's up. Thank you, everybody.
Yeah.